welcome Dr. Walid Kadiro, who is the Chief of Cardiology and Director of the Cath Lab and Interventional Cardiology, the Senior Consultant Interventional Cardiologist of Sulekha Hospital, Sharjah, UAE. Welcome, Doctor. And you will be talking on hypertension control in pregnancy.
Yeah.
Timing and the choice of pharmacological therapy. Welcome, Doctor. Yeah.
Okay. Thank you very much for the nice introduction. Let me first also thank the organizing committee, Dr. Lin, and the Asia Pacific Hypertension Summit. And I have to really thank the Emirate Cardiac Society who selected me to be their representative in this symposium. I'm a cardiologist originally from Damascus, Syria, but I've been practicing in the UAE for more than 5 years. So let me share my screen. Okay. Can you see my screen now?
I'm not seeing. So what about other people? Yeah, now it's okay, Doctor. Yeah.
Okay. Okay. So I'll be covering the topic of hypertension in pregnancy and the timing of starting treatment and which pharmacological agent to use. So we'll start with some introduction about hypertension in pregnancy, and I'll use the term HDP, that's hypertensive disorder of pregnancy. Let me advance. It's not advancing or what? Okay, I'm sorry, I have to reshare again. Okay. Okay, I'll put it on full screen. Okay. So the hypertensive disorder in pregnancy are a major cause of maternal and fetal morbidity and mortality, and it accounts for about 10% of pregnancies worldwide. This may increase due to the increasing age of pregnant women and the obesity, increasing obesity in the conceiving women. So it is important to distinguish about the types of hypertension in pregnancy, and we'll go into those definition a little bit later. There is a consensus that we need to treat severe hypertension when the systolic high blood pressure is more than 170 and diastolic blood pressure more than 110, and consider that as an emergency and the patient need to be hospitalized. So the current European guidelines recommended starting treatment for persistent hypertension when the blood pressure is more than 150 systolic and more than 95 diastolic. That's totally different from the recommendation from the European Society of Hypertension and the American College of Cardiology for treating non-pregnant women. We know that we have to get the blood pressure more tighter, less than 140, and in some studies less than 130. But for the pregnant woman is a little bit different. And when there is other comorbidities, especially in the presence of gestational hypertension with or without proteinuria, or pre-existing hypertension that was with superimposed gestational hypertension, we need to start treatment when the systolic blood pressure is more than 140 and the diastolic more than 190. There are a lot of of medication, but the data on Leviteral, methyl dopa, and calcium antagonists are the most available data. And the selection of antihypertensive depend on the type of administration and the expected time of delivery. So there are two major studies. One published in 2015, the SHIP study, and the CHAP study, which was published last year in 2022, recommended that that we should lower the threshold of initiating hypertensive therapy in the woman, in the pregnant woman. Just to remember that the woman with hypertensive disorder of pregnancy, especially preeclampsia, they have a high risk of developing another cardiovascular or major cardiovascular event later in their life. So we need to recommend the obstetric history, and that should be part of the cardiovascular assessment in every woman. The pregnant woman with hypertensive disorder of pregnancy also is at increased risk of abruption, stroke, pulmonary edema, thromboembolic events, and DIC. The fatal risks include growth retardation, intrauterine death, and the neonatal risk includes increased preterm birth, low birth weight, and prolonged neonatal care. So there are some physiological changes in the blood pressure during pregnancy. So early in the first trimester of pregnancy, there is significant drop in the blood pressure due to vasodilation and production of prostacyclin and nitric oxide. And this may cause the blood pressure to drop by 8 to 15 millimeter in the diastolic blood pressure, and followed by gradual increase after the week of 24 of pregnancy. This blood pressure fluctuation is seen both in normotensive and hypertensive women. So some of the patient with who has a history of hypertension may be found to have normal blood pressure, and once their blood pressure rise after the second trimester, they may consider to have gestational hypertension, although this is misdiagnosed as gestational hypertension because she has chronic hypertension. The blood pressure usually falls immediately after delivery and does start to increase again 3 to 4 days postnatally and continue to rise. And remember, 10% of maternal deaths is due to hypertensive disorder in pregnancy, and the mortality occur about 10% in the postpartum period. So those are the hemodynamic changes in pregnancy. That's for the blood pressure. Just remember, the pregnancy is like a small exercise stress test. There is increase in heart rate, increase in stroke volume, and increase in cardiac output. So what are the classification for the hypertension in the pregnancy? There is gestational hypertension. That means the blood pressure rising after the week of 20 weeks of pregnancy and continue to rise during the pregnancy and start to fall down after 6 weeks of the postpartum period. The preeclampsia, when it's associated with other organ damage, chronic hypertension when the blood pressure is present before pregnancy and is mainly at the beginning of the pregnancy or before the 20th week of pregnancy. There is the chronic hypertension with superimposed preeclampsia and chronic hypertension with superimposed gestational hypertension. So what's the number? The definition is when the blood pressure is more the 140 systolic and 90 diastolic. That's gestational hypertension when it occurs after the 24th week of pregnancy. When it's associated with proteinuria or not necessarily proteinuria, one of those following findings: low platelets, microalbuminuria, increase in creatinine, increase in liver enzyme, pulmonary edema, headache, visual symptoms, all of that are eclampsia. When it's associated with convulsions, all of that are preeclampsia. When it's associated with convulsion, it's called now eclampsia. And just remember, chronic hypertension is in the back of all of those things. And preeclampsia is known as, it's not just hypertension, it's multi-system disease with progressive disorder. So points to remember that pre-existing hypertension is associated with 25% increase in the risk of developing preeclampsia. So every patient with pre-existing hypertension is a high risk of developing preeclampsia. And there are some cases of what we call transient gestational hypertension, where the blood pressure rises a little bit and then come back to normal within few minutes or within few hours. And just remember, this is not a benign condition. It's associated with 40% increase in gestational hypertension or preeclampsia. So this is not a benign condition. So every patient with some transient elevation in the blood pressure should be followed closely and monitor for their blood pressure in order to document the diagnosis and put the plan for the follow-up. So what are the prediction of developing preeclampsia? There is what we call the high-risk patient. The high-risk patient are the patient with previous pregnancy associated with preeclampsia and fatal gestation. The patient with a twin or triplet are at high risk of developing preeclampsia. Chronic hypertension, as I mentioned, is a high risk for developing eclampsia. Type 1 or type 2 diabetes, renal disease, and autoimmune disease, whether SLE or antiphospholipid syndrome. So there are some moderate risk cases. The moderate risk cases is the primiparity or nulliparity, the patient with no history of previous pregnancy, obesity, and increased BMI more than 30, family history of preeclampsia. If the patient mother or sister had a history of preeclampsia, she is considered as a moderate risk. Extreme age, when the age of the age of the pregnant woman is more than 35 years, and even at the lower age, less than 18, it is considered moderate risk. And some socio-demographic characteristics like African American women and low socioeconomic levels. There are some other personal risk factors. If the pregnant lady has herself history of low birth weight when she was born, or a small gestational age, or previous pregnancy, poor pregnancy outcome. And another factor is the increased time interval between the pregnancies due to use of prolonged contraception or use of condoms by the sexual mate. So what's the management? It's the management of hypertension and hypertension in pregnancy is like a balancing act between the maternal benefit and the fetal health. So best care for the mother result in fetal growth retardation, and the best care for the fetus may put the mother at risk. So what's the management? The management is to control of hypertension by using hypertensive medication, prevention of eclampsia, and early delivery. So we'll try to cover the important points of control of hypertension. So and the management, just remember that the patient with mild pre-existing hypertension, where the blood pressure systolic is between 140 to 160, they are at low risk of vascular complication, cardiovascular complication in the short time frame of pregnancy. And if the patient has essential hypertension but normal renal function, they are at low risk of developing maternal or neonatal bad outcome. bad outcome. Some women treated with pre-existing hypertension and mild hypertension, we can withdraw the medication during the first trimester or the first half of pregnancy because of the physiological drop in the blood pressure that we mentioned before. However, close monitoring is necessary for resumption of treatment. So what are the target? The target is not like the target that's mentioned for the Society of Hypertension or the European Society of Cardiology or the American College of Cardiology. We are not going to hit the target here. We are going to go a little bit different. Because drop in the blood pressure may affect the blood supply to the fetus and give a poor outcome. So we have to consider this other symptoms and consider the syndromic approach. So if the patient has a high blood pressure in association with any of those things like thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, or new onset cerebral disturbances, whether it's headache or visual disturbances, thus we need to start the treatment, whatever the number is there. And the principles is when to treat and what's level of hypertension to reach and how to treat and what to use for medication and what to avoid. The level, as we said, when it's severe, that's more than 160 systolic, 110 diastolic, that's severe, need to be treated. Moderate, 150 to 159 systolic and 100 to 109 diastolic. Mild is 140 to 150 systolic and 90 to 100 diastolic. So if we concentrate on the diastolic, that's so for severe hypertension, always recommended to treat because it is believed to reduce the risk of maternal stroke. For mild to moderate hypertension, it's prudent approach because we need to consider the other comorbidities and the symptoms of the patient, like headache or visual disturbances, and thus we'll start treatment. Because the benefit and potential risk of treatment is less clear. So the concern that aggressive lowering or medication of blood pressure or medication themselves may inhibit fetal growth and expose to harmful effect or side effect of the drug. So when to start? As we said, when the diastolic, to start for the diastolic blood pressure at a 90 or 100, we know that maternal treatment did not increase the risk of fetal growth retardation and did not cause excess fetal risk when we decrease the blood pressure diastolic to 85. And this is in the CHIP study that I did mention and was published in 2015 in the New England Journal of Medicine. So dropping the blood pressure to the diastolic to 85 did not increase the risk of fetal growth retardation and did not do any harm to the fetal risk and give less progression to severe hypertension. So when to start? As we said, immediately when the systolic blood pressure is high and associated with symptoms. We can watch the patient for 2 hours when the systolic blood pressure is high, more than 170, but without symptoms. We can watch the patient for 24 to 48 hours for observation and start the treatment when there is systolic blood pressure more than 140 and diastolic more than 90 at any time, but after observation for 24 hours. If there is gestational hypertension, whether it's associated with proteinuria or not, need to be started after 48 hours. Pre-existing hypertension with the superimposed gestational hypertension and hypertension with HMOD, that's called hypertension mediated organ dysfunction, whether there is epigastric pain due to liver congestion, visual disturbances, or headache. And whenever the systolic blood pressure is more than 140 or diastolic more than 95, in all other circumstances, after watching the patient for 24 to 48 hours. The benefit that we know that reducing blood pressure reduces the occurrence of severe maternal hypertension during pregnancy, and did not, in one study, that the SHIP study did not affect the preeclampsia or the maternal stroke. This is in one study, but there is a new study that was published last year about that's called the CHAP study. That's treatment of mild and chronic hypertension during pregnancy, and that showed significant reduction in the maternal outcome. That's the occurrence of preeclampsia without any effect on the fetal outcome, without any increasing the damage to the fetus or fetal growth retardation. So that's the primary outcome of preeclampsia and severe feature. There were significant reduction with significant p-value. So the safety, what are the safety of a hypertensive medication? Just remember, all hypertensive medication cross the placenta, but there is no data or randomized study on any of the drugs. But the best drug which was studied longitudinally is methyl dopa, but we hardly use this medication. So how, what are the points to remember in treating hypertension in pregnancy? To avoid ACE inhibitor, ARBs, and direct renin inhibitors, all of that associated with renal anomalies and damage to the fetus. So that's avoided. Also, minor corticoids with spironolactone or epinephrine that may affect the fetus and cross the placenta, and is not studied in the pregnancy. So that's to avoid. Thiazide diuretics, it may reduce the intravascular volume, so it should not be used unless there is pulmonary edema. And it can be used after the delivery postnatally if hypertension persists, to prevent eclampsia or congestion. The nitroprusside, we need to avoid that because of the risk of the cyanide poisoning. So it should be used only as an emergency and for short period. That's the nitroprusside. So we did mention all of that. So what to use? The emergency hypertensive treatment for hypertension is Leviteral is the first drug and can be given IV stat and repeated every 30 minutes, or can be given infusion with fewer side effects. There is some contraindication, like the contraindication for beta blocker, asthma, or heart disease. Hydralazine can be used IV or IM or infusion. It has side effect, headache, fetal distress, and some hypotension, and may cause also some fluid retention. Nifedipine can be used, especially the oral or the long-acting one, and can be given, and it can act quickly within 30 minutes and can be repeated. Just the most important point is to try to avoid short-acting sublingual nifedipine. It did increase the incidence of MI, and this is considered malpractice to use sublingual nifedipine. To maintain the antihypertensive treatment, Lipideral can be used orally with a dose of 200 to up to 2400 milligram a day. Nifedipine can be used with a maintenance dose of 30 to 120, and methyl dopa can be used with a dose of 500 to 2000. Lipideral has both alpha and beta adrenergic blocking activity and may preserve the uteroplacental blood flow. And in some study, it may reduce the incidence of proteinuria. It has more rapid of action compared to methyl dopa. Lipideral may have some hepatotoxicity and some adverse outcome, especially in chronic hypertension. There are some limited data on the other beta blocker like Bendelol and long-acting metoprolol. So hydralazine, as mentioned, can be used orally, and hypotension is really difficult and less predictable. It may happen, and it may cause fluid retention and reflex tachycardia. For nifedipine, it is safe, immediate release, and sustained release for the maintenance. As I mentioned, avoid using sublingual short-acting. The data for other calcium channel blocker like amlodipine, felodipine, verapamil, and diltiazem are lacking data. Methyl-dopa, it is widely used, it's safe. We have data for long-term safety for this medication was followed for more than 7 years, but it has only mild antihypertensive effect and has slow onset of action. It may take up to 24 hours to work and will not achieve target blood pressure. However, it is well tolerated. Clonidine, it has some side effect and may cause rebound hypertension. So we'll try to avoid it, but postnatally may be used. Nitroglycerin is an option for treating pulmonary edema and can be given in infusion. The other treatment are bed rest. There is no data about bed rest may prevent the exacerbation of hypertension, but it may improve the uteroplacental blood flow. But the data are really rare. So patient with stable chronic hypertension is not recommended to get bed rest in order to avoid the risk of thromboembolism. The salt restriction, also there is no data for salt restriction, and salt restriction may deplete the intravascular volume. So we'll try to keep the patient on their regular salt diet. Magnesium sulfate, it's not as an antihypertensive, but it may improve the response of antihypertensive and prevent the progression of preeclampsia. So our target, as we said, is not the target in the middle, is try to do that a little bit for systolic blood pressure 130 to 140 and diastolic between 80 to 100. And how rapid can we do that? It's controversial, but just remember a quick drop in the blood pressure may cause cerebral ischemia or infarction. So we'll try to reduce the blood pressure up to 25% of the number over 2 hours. So what other intervention can we use? It's mainly to educate the patient about the symptoms of preeclampsia and teach them about those symptoms so they will notify their doctors as soon as those clinical manifestations show up. Follow up in high-risk women, for the high-risk woman for frequent visit to check her blood pressure and check the other blood test. What other intervention? Losing weight, especially in the obese patient, and not to exceed the recommendation for gestational weight, and try to reduce the chance of multiple gestation, especially if the patient getting IVF. If the IVF getting her multiple fetus, that's increased the risk of developing preeclampsia or blood pressure. Low-dose aspirin is really beneficial to prevent the incidence of preeclampsia. Calcium and antioxidant are considered to reduce the risk of preeclampsia. So let's talk about, a little bit about aspirin. Aspirin, there is meta-analysis of big study, more than 40,000 women. It showed reduction in proteinuria and preeclampsia. It showed the reduction in fetal and neonatal deaths, and reduction in preterm birth, and reduction in small for gestational age. So all the composite series adverse maternal and neonatal event outcomes has been improved. So, but however, if we continue giving the aspirin, it may increase the risk of postpartum hemorrhage, but it doesn't affect the incidence of abruption, and there is no evidence of affecting the incidence of HELLP syndrome. So we'll give aspirin, as we said, to the moderate or high risk of developing eclampsia, and I did mention those moderate and high risk at the beginning, and the high risk multiparas, especially in the IVF patient, and the high risk per algorithm, whether due to proteinuria or increased blood test like elevation of S-FLET. The aspirin after preeclampsia doesn't give any benefit. So if we need to give aspirin, we need to give early at a dose of 81 to 150 milligrams. Start that before the 20 weeks of pregnancy, especially prefer to be started at 12 weeks of gestation and continue and stop that at the 30 week of gestation, or at least 7 to 10 days of before the delivery. Calcium, it is documented that it may reduce the incidence of preeclampsia. So it is recommended to give some calcium, but the dose is not well studied. Low molecular weight heparin has no benefit. Remember, statin are contraindicated during pregnancy. Vitamin C and vitamin E supplement is not recommended. The other thing is vitamin D may reduce the risk of preeclampsia. Folic acid has no effect, and fish oil has no effect. So nitric oxide donor also has no effect, although they give vasodilation, but has no effect to prevent preeclampsia. Just hypertensive drug, it may reduce the progression of hypertension. And as I showed you in the study, it did improve the maternal outcome. The diet, there is no beneficial result of any diet, whether to increase the protein or reduce the protein, increase the magnesium, or do salt restriction. Behavioral changes are a little bit important. There is no strong evidence, but to do regular exercise may prevent the progression of gestational hypertension, may prevent the development of gestational diabetes, and prevent the other side effect. So there is some points to remember about prognosis after pregnancy, that the woman with gestational hypertension has a risk of developing hypertension and stroke later in their life. So and also preeclampsia are associated with four-fold increase of developing hypertension and developing ischemic heart disease, stroke, and cardiovascular death. So every patient with hypertensive disease of pregnancy she's at risk of developing hypertension probably 10 years later. And the echo study showed that they continue to show some diastolic dysfunction compared to the other patients who developed hypertension but did not have any history of hypertensive disorder of pregnancy. So we need to follow those patients and get all their obstetric history. And once we get those obstetric history, we can follow them regularly. And just remember also, hypertensive disorder of pregnancy may affect also the cognitive function of the mother, and they may develop vascular dementia later in their life. And also there is some study showing that they may affect the cognition of their fetus. So follow-up after pregnancy, we need to do close follow-up even after the patient discharge, give her blood pressure monitoring device so they can report high blood pressure in the postpartum era. If they develop high blood pressure, they may progress either to what we call late onset postpartum, late onset preeclampsia, or they may develop postpartum cardiomyopathy. So all the cardiologists and the general practitioners should include the obstetric history of those patients and get that. With that, we'll stop here. I don't think we need to do any other points. I think we covered most of the points. There are some points that's for the obstetrician, how to deliver, but I don't think it's the appropriate place here to discuss. We are a hypertension society.
Thank you, Dr. Walid, for his excellent and elaborate talk on hypertension in pregnancy. Thank you so much. So next is because of the shortage of time. So I don't we need to